And just want to highlight our wonderful playlist today from DJ Jimberly. Remember to tip your DJ, and many thanks to the ATN collaborators who gave so many great suggestions for this playlist. So we're going to get started in a second, but here are the speakers you'll be hearing from. We're going to start off with Lisa and Sybil, who are the Adolescent Trials Network's principal investigators. We're then going to move on to Kate and Audrey, who are going to be talking about a project called Linking Youth to PrEP Services, otherwise known with the acronym LYPS, one of the best acronyms out there. So they will be kicking us off with so it'll be Sybil and Lisa, Kate and Audrey, and then we'll move on to Sari and Kristi, who also have a good acronym, LEAP. They'll be talking about legal, economic, and affirming peer support, a new study from the ATN. And then we're going to have a roundtable discussion with Zoe and Kendrick, who are subject matter research consultants, as well as Rodrigo, who is a National Community Advisory Board member. So I am going to stop sharing now, and I'm going to invite our wonderful pair of inaugural or opening speakers to come to the virtual floor and kick us off. So go ahead, Sybil and Lisa.
Lisa, unmute.
Better? Can you hear me now? Sorry, the muting and sharing. It's hard to do two things at once. So thank you all. Thank you especially for Jim for inviting us with the ATN to speak with you all. We're gonna just do a little bit of an intro as to what the ATN is. I saw on the invite list and in the chat, a lot of you are internationally focused. The ATN is specifically focused to domestic youth, but I think that there's a lot of things that we're doing that are important, globally, and a lot of potential for collaborations with the ATN and other research networks and other groups. So the ATN has been around since 2001. It's completed its four funding cycles. We're currently in what we call ATN 5. The last ATN ran from 2016 to 2022 and had a sort of a different slight focus where there was sort of groups that had focused on specific areas. In this cycle of the ATN, NICHD, who's the primary funding group, really wanted to kind of create a new structure, a new network, so to speak. And Sybil and I really kind of think of this as multiple cogs that all are working or hopefully eventually all working together to achieve the goal and the mission of the ATN, which is really to end the epidemic among adolescents and young adults age 13 to 24 in the United States. And obviously it's a lofty goal, but we're very excited about all of the studies that we have, but certainly the two that you'll hear about today. There's a lot of different pieces in the ATN. Sybil and I live in the Scientific Leadership Center. There's also other pieces that we'll try and kind of talk you through. So that's me and Sybil. I should say that we've been focused on working with adolescents and young adults at risk for living with HIV for really the entirety of our careers, which seem to get longer and longer. So going on 20 plus years. We've been working collaboratively together for nearly 20 years. We bring unique and different skills. I'm trained as a MD in ID. Sybil is trained in clinical psychology. We really, however, share the same guiding leadership principles, which we're trying to put forth across the ATN in how we think about doing this challenging work. So responsiveness, efficiency, we have, we continue to try and improve in these areas, collaboration. And again, we mean this across the network, but also outside of the network as well. And we really invite folks who have interest in doing work in the ATN to reach out. Transparency, and really the key, and I think you'll hear this from the SMRC and NCAB at the end, is to try our best to be youth focused in all that we do. The other thing, which is something that we've really taken a real important focus on in the ATN, is on health equity and inclusion. And this cuts across all of our studies, our protocols, our teams, and the work. In fact, that we developed a health equity assessment, and one of our health equity teams that's part of the ATN is applying this across the network as a whole and across each of the protocols. And it's a living, breathing document and assessment so that we can actually make sure that everything that we do really does focus on health equity and inclusion. The other piece you'll hear from Kate Messig today, who is leading a protocol, but she also leads the SDMC along with Audrey. So they're kind of doing double, triple work, and they're working with a statistical management group called MS, and these folks are really kind of doing the heavy lifting of ensuring across all of our projects and protocols that we have data management, data analysis support, support for clinical and lab collection. And really, Audrey has been leading our scholars program, and it intersects with her role in the SDMC around really kind of promoting equitable use, accessibility, and dissemination of data. I'm going to turn it over to Sybil, who's going to take us home for our little part.
Sure. Thank you, Lisa, and thank you, Jim, for organizing this. I know it seems like we're going really quickly through the structure of the network, but I think the structure is only one piece, and we really want to spend more time highlighting the other pieces on this call. And also, Jim is furiously dropping links into the chat, which will give you more information on all of these different components. But our scientific leadership group really is the key scientific hub that configures and addresses all of the studies moving forward in the ATN. And we wanted to do something a little bit different. A lot of, I think past networks sort of focused on different populations and have groups dedicated to specific populations, but our entire population is young adults and adolescents. And we wanted to be able to focus more on the content areas and the barriers and facilitators and things that influence youth and influence the HIV epidemic in the United States. And so, we do have a biomedical therapeutics, which is our prevention and treatment scientific leadership team. We also have a laboratory diagnostics and mobile technology, and really kind of thinking about all the different ways to measure adherence, the different ways to engage youth with digital health. We have an equity, inclusion, and engagement team, which is really focused obviously on ensuring that we have the health equity that Lisa mentioned across all of our protocols, as well as youth engagement throughout. We have, which is a little bit different from our past network experience, institutional organization and policy group, which is really focused on, impacting the HIV epidemic from a policy perspective and working within organizations and institutions to further policies. And that might, be informed by our science, but also helps to change, prescribing practices and policies around youth consent, et cetera. And then we have the assets, resources, challenges, and context, ARC, which is quite a mouthful, but really is focused on kind of the facilitators and barriers and a lot of the socio-ecological factors that influence youth and HIV vulnerability. And then we also have a bioethics committee, which kind of centered in the middle of that, which is a kind of a consultative body, but really helps to influence all of the work that we do. Thanks, Lisa. Go ahead. We have, I think, the most amazing communication and dissemination hub, which is called the CD Hub. And really this group came out of the last ATN and Lisa's work around kind of thinking about how do we start to talk about studies before we get this kind of, lay summary at the end and try to explain that to communities. And so it's really about bringing the research from the beginning, disseminating it in a way that is digestible and interesting and compelling. And I hopefully encourage all of you to be following all of our social media channels, which I'm sure Jim can probably drop those in the chat as well. And you'll see some of the amazing work that this group is doing. And then we have our youth leadership. And again, like Lisa said, we're trying really hard to center youth in this network and to make sure that their voices are heard throughout all of our procedures and processes and protocols. We have two complementary groups of young people, and you're going to hear from some of them today. The subject matter research consultants are actually young professionals who may kind of be in the age range or just past the age range of the people who would be in our studies. But these are our paid consultants. We actually pay them to be part of our group, to inform us, to help us on protocol teams, to be on the scientific leadership groups. And then our National Community Advisory Board, which is similar to kind of a normal CAB, CAB that people see across studies, but their role really is to interface between at the national level with their home sites. So each of them comes from a site. And then at each of the sites, there's also a youth advisory board. And so our NCAB members are really kind of keeping that bi-directional communication open between the national level and the site level. We collaborate with Westat, with Barb Driver and Dan Reardon, who we've collaborated with for years in the ATN and in other facets. They lead our Operation and Collaboration Center along with Dina Monte, and they're really focused on supporting, obviously, the operations, but also the sites. So all of the site work comes through them. And speaking of our sites, these are our ATN site consortiums. The ones in green were just recently added. So we're really excited to have, now we have 13 anyway. Okay, so moving on, we're going to hear today about ATN 165 and ATN 167. I'm not going to go into detail about all of these. ATN 164 is a testing strategy, HIV testing strategy in the emergency room. ATN 166 is a digital health, mobile health technology intervention. These are all clinical trials, so they're all at some point randomized clinical trials. I do want to highlight a couple. One is ATN 168 and 172, which go together. This is focused on multipurpose prevention, initially starting off with a discrete choice experiment across all of our sites to really explore preferences among US adolescents. But then hopefully, and I see Gustavo on the line, we will have an actual product to do our phase 1 first in human studies within the ATN as part of ATN 172. So we're collaborating with Conrad on that protocol. And then we have a couple of protocols that are already approved and in development. But again, to highlight ATN 173, DoxyPep, which is a study focused on the efficacy of DoxyPep among youth assigned female at birth in the United States. Right now, we have evidence supporting that use among gay men and trans women. We need products to be able to reach the entire population. And so we're pursuing that protocol within the ATN as well. And then Lisa already mentioned our ATN mentorship program, which Audrey Pettifor is leading. We have our first set of scholars starting this month, but we will have another call in the fall for our next cohort. So please be on the lookout for those. I'm going to stop there. And I don't know if we did that in 7 minutes, Jim, but I think we did. No, we didn't. I went over.
See, I told you, you went over by like 30 seconds. Man, no, that was great. Thank you so much. And everyone will have access to the slides so they can pour over them more. We do have, before we move on to LYPS with Audrey and Kate, we do have a question from Cedric in the QA, and his question was around protocols and development. Can you share a little bit more on the concept of protocol ATN 173 and which of your sites will be taking this on?
So that is our DoxyPep protocol. We are just at the very beginning of concept development, so sites have not been chosen. We're hoping to have at least 10 sites to be able to contribute, and we're really trying to focus on areas where there's high STI prevalence. And we're also exploring collaboration with other HIV networks within the United States that perhaps can reach a slightly older population. So I would say stay tuned on that, but that's very early. I would say that protocol probably won't launch until the fall.
Thank you. And I also saw something new that's coming, another amazing acronym, SASSY. Can you please tell us what SASSY stands for?
Go ahead, Lisa. I can never remember what it stands
I
for.
don't remember, but it's
I can, this is
Justin, you're on. What's
Tom.
a
Justin,
SASSY?
good.
Yes. Sequential adaptive strategies for supporting youth.
Yeah.
It's a sequential multiple assignment randomized trial to address alcohol misuse and HIV related outcomes.
I wanted to call it binge, and no one, that was easier for me to remember. But yeah, this is a protocol that Justin Knox and Elvin Gang have put through, that we're pushing through, that really focuses on adolescents using alcohol. So again, there's lots of ways. There's a link on the website to submit concepts. You can always reach out to Sybil and myself to talk. We're happy to entertain more and more ideas. We just need more and more money. So if you have money, please definitely reach out to me.
Thank you so much. And look, please stick around. We'll have time for Q&A when our presentations are done. So I'm going to now invite Audrey and Kate to come to the proverbial floor. And please turn on your camera if you can. And go ahead and take us through LYPS. Thank you so much.
Great. Good morning. Good afternoon. Whatever time of day it is for y'all. I'm Audrey Pettifor. I'm at UNC. I'm one of the MPIs of LYPS. And Kate and I are going to be presenting this morning. So I'm going to do the first couple slides, and then Kate will do the others. And then our other investigators, Dr. Keith Horvath, who could not be here with us this morning, but I know is here with us in spirit. So we're sharing with you LYPS, which stands for Linking Youth to PrEP Services. And this really came from a desire to get PrEP services out of clinics to young people. And I will say also was really born from some work that I had done in South Africa with Linda Gale Becker's group. I think there's been a lot of innovation in other parts of the world that the US can learn from, particularly in the adolescent space. And so I think this is a really exciting innovation where we're trying to address some of these multi-level barriers to care that young people face, and not young people, but especially young people, right, that place them at incredibly high risk of HIV. And in addition, that we see such low levels of PrEP uptake and adherence. So, things like transportation, clinic hours, obviously costs. And in this protocol, the drug is actually being provided by the study. So that's kind of not an issue, which will be an issue, I guess, for other folks. Stigma and discrimination, side effects of drugs, and providers who aren't youth-friendly, obviously, are all challenges that that young people face. So what we're trying to also do is support, the day-to-day management and support for engagement and barriers to PrEP adherence with mHealth. So this intervention is both bringing PrEP to young people and helping support them through an app. Next slide. So we're kind of building on this model of differentiated models of care, particularly trying to address, getting care out of the clinic. And I think also what's innovative, although there have been studies looking at getting oral PrEP out of the clinic, in this case, we're also providing cabotegravir. So I think that will be an interesting, challenge, but also opportunity to learn how we can provide cab out of the clinic. So we know that priorities for differentiated care include, looking at offering more choices. So in this environment now where we have oral PrEP and cab and 211 and more choices to come, kind of how do we support that choice for young people? We are looking at different delivery approaches. So for injectable PrEP. So we'll talk later, but certainly thinking about, how and where do you provide this PrEP? And how can we also leverage customizable mobile health tools to support adherence? So those are all things that we are going to be looking at in this study. Next slide. So when we talk about differentiated care and choice, the things that folks think about is like, when is this product going to be delivered, and what best suits the needs of the young person taking it? Where is it going to be delivered? And that's something that our sites are thinking about. So is that a community? Is that in the home? Is it a drop-in center? Other studies out there are looking at things like pharmacies, who's going to deliver the service, and what is in that package of services. And in our case, it is predominantly HIV care, HIV prevention care, but other differentiated care models, are looking at packaging PrEP care with other services. So, CAB offers this other question of, again, there's some regulatory, I guess, like constraints about who can provide injections, where it can be delivered. We've had some sites say, yeah, like we're not going to be providing CAB in the McDonald's bathroom. If that were a place somebody wanted to have it, So we have to think about kind of just safety and where we can do it, and, what else needs to be delivered with CAB. Next slide. So these are the aims, and I think, am I handing this over to you now, Kate?
Sure, I can pick up here.
Okay.
So the study has two overarching aims. First of all, for this particular study, we are focusing on transgender women and gay, bisexual, and other sexual minority men in the ages of 13 to 24, which is the ATN's age range. So our research aim for the science side will be looking at, does this model of delivering PrEP outside the clinic, which we'll talk about the different components, does it improve PrEP adherence as well as persistence at 6 and 9 months? So not just helping people take their PrEP in the way that they've decided to take it, but can they stay on it longer? Because we know drop off and on is one of the challenges that young people are working through, particularly in the US. And then we're also looking at the cost and the cost effectiveness of this intervention. We realize that we could design the perfect intervention, but if it's not something that can be justified and scaled up from a resource or cost perspective, it'll never get out there. And we're trying to think about this in a way that doesn't necessarily say, we don't necessarily think this model will be cost effective for everyone, but we do think that it might help reach individuals who are facing, some of the highest barriers to engaging in PrEP. And so we want to be able to make the argument that it's not an absolute dollars cost that we're looking at, but the overall package and overall PrEP delivery program that a clinic or organization might be able to offer. These are our current 4 sites, so we have some great geographic diversity. We're also trying to think about not just strictly urban settings, but also what this might look like outside of some of the more densely populated areas. But these are our current 4 sites that we're starting with. And then the intervention components, Audrey alluded to some of these, but basically all participants will be provided the PrEP medication of their choice, whether that is Truvada, Descovy, or injectable CAB. And everyone will have the standard of clinical PrEP care at their clinic, as well as referral to any other services, STI testing, ongoing HIV testing, and supportive services that the clinics offer. And then everyone will also receive a basic version of the interventional app, which is based on health empowerment platform that Lisa has developed over a number of years and that is in use among many studies within and outside of the US. And the basic version of the app provides all the informational resources and educational resources around PrEP and sexual health and health areas more broadly, mental health, substance use, things that young people have said are important to them. Then in the intervention arm, in addition to those pieces, we'll also get delivery of PrEP outside of the clinical setting. And we'll talk about the different models that looks like. And in addition, they will get some additional tailored ongoing adherence support and tracking in connection with that out-of-clinic service PrEP delivery. So we have been working closely with our sites and with our subject matter research consultants and members of the site community advisory boards to develop what these delivery models look like. We recognize that to be successful, each model will have to be tailored to the specific setting and clinical practice where it's being delivered. So as Audrey mentioned, these are some of the models and venues that are currently being developed, including mobile clinics, community-based organizations and centers, as well as the potential for a home visit where a healthcare provider would come to an individual's home or place of residence. So these are still currently in development, but this is where we are so far. And Audrey mentioned some of the challenges, but really, when we think about safety, we want to think about safety both for participants as well as research and clinical staff. So working through that in these different settings, obtaining study drugs, as we want youth to be able to have the choice of the type of PrEP. And so it takes extra time to be able to secure the availability of sufficient study drug to be able to provide that as part of the study. We are discovering challenges around variation in laws across state for how CAB-LA is delivered in the US, and then thinking about, again, CAB delivery outside of the clinic, considerations around cold storage for both the medication as well as any biological samples. We're hoping to be able to start the study in mid to late 2024, and then would have results sometime in late 2026. And just some implications, as Audrey mentioned, I think this protocol really draws on successes and innovative approaches that have been successful outside of the US. And so we would love to see how this works in the US, and are there other ways that we could have lessons shared across different settings. So as we mentioned around the cost effectiveness, being able to look at that model and what that might look like in different care delivery settings, whether in the US or outside of. And then the service packaging, if we think about if this were to be done with cisgender women, what kind of combined packaging would go along with PrEP outside of the clinic. And just acknowledge our broader protocol team and leads across the ATN, as well as our site representatives and our subject matter research consultants. And we have a bunch of references at the end for those of you who are interested in more information. Thanks.
Thank you, Kate and Audrey. That was fantastic. All those links that they showed were dropped in the chat. We will be bundling them into a resource document. And we have a couple of good questions coming in. Cedric has another good question. Cedric, would you like to come off? I'm going to put you on the spot. Would you like to come off mute and go on camera and ask your question, or do you want me to ask it for you?
Hi, Jim, thank you for putting me on the spot. Sorry, I'm
Anytime.
not in traditional attire. So my question is related to what sort of resources co-chairs and the protocol team are exploring to help with financial support when it comes to sustaining participants on injectable, mainly injectable is the question here, because we know oral PrEP, there's way more financial assistance with copay assistance and things and additional copay assistance. But I asked specifically because the FDA mandated viral load testing that's required for injectable PrEP and those routine appointments and testing appointments. And so just wondering what sort of, I would say, financial sustaining ideas has the protocol team thought about for this particular study? Thank you.
Yeah, that's a great question. That's come up very early, I think, as a question from sites as well. And so what we are wanting to develop is basically a guide that from the time really that someone enters the study, that we're also kind of thinking about the end of the study, right? So a lot of what sites have told us is that the process of even just getting approval to get someone on CAB takes a long time. And so they're often starting people on oral, and then once they get approval, transitioning them to CAB. So if you think about, if you could start them on CAB as part of the study and then have that process going alongside of getting approval so that when they're rolling off the study, that approval is in place, that they could continue it outside the context. We also want to build into the second to last and last study visits, basically a continuation counseling to work with the individual, basically like a prep navigation component to think about, what are your next steps when you get to the end of the study? What do you want that to look like, and what do you need to support wise to continue that? But it's a really great question.
Thank you so much.
And I would also say on the viral load testing, I think that's something we've had a lot of conversations about in general. And I know, like even in our ID seminar here, questions, I will be really interested to see where that goes, where that recommendation goes, especially in international settings, but even in the US, right, as you pointed out. So, because there's been interesting data, and I'm an epidemiologist. This isn't like totally my area of expertise, but from some of I think from HPTN 083 and 084, there were not that many people who, when you look at the volume of people who were on CAB, the number who actually had acute infection or, was small. And so how much will this viral load testing be more of a barrier to getting people on effective CAB and preventing infections versus the risk of people on with acute infection who might, then develop resistance? I think that's going to be a really important question to grapple with as CAB gets rolled out, because it feels like a big barrier right now.
Thank you both.
Thank you for that great question. Thanks for it's definitely a watch this space kind of moment for that. We have one more question, and I think I've successfully lured her to come on camera. Grace, do you want to ask your question on camera?
Thank you so much, Kate, Audrey, and Jim. I think this is amazing work. So I was just trying to understand the context of the US in terms of your PrEP standard of care. What is already included? Do you have appointment reminders? Do you have additional information being provided? And just trying to understand what really entailed you to make the decisions around which strategies to go for the intervention arm as compared to the other one. So I just wanted to understand the thinking around that. Thank you so much.
Super timely question, Grace. We've actually been, at least for the app, we were all talking about, deciding what is standard of care, what should be standard of care, what should we provide in the app just for the intervention group versus the standard group. So I have worked in Southern Africa for 25 years, and I am new to working in the US, and my sense is that certainly the app space and texting space for support for PrEP is not standard of care. And that's why we're kind of testing this. But I would open it up to Kate and others and Lisa to talk more about what is standard for, follow-up and PrEP adherence for folks in clinical care.
Yeah, I think we will have appointment reminders across both arms. I think just as part of the research protocol, and I think most of our clinics probably have that in place in terms of appointment reminders. I think what's maybe less consistent across sites is how much resources are dedicated to following up with people who don't show. So you can send that reminder, you can send the second and third reminder, but then when you've lost people to follow up care, do you have the PrEP navigator, or do you have the community outreach to go and then find that person? And I think that's definitely not the standard of care across most clinical settings in the US. I think some particularly large and well-resourced centers do have a bit more of that, but it's not standard.
Thank you for that great question, Grace. And thanks again, Audrey and Kate, who will be sticking around for our final opportunities for QA and discussion. So I'm going to invite now Kate, I'm sorry, we're going to take a leap forward with Kristi and Sari, who will be talking about the LYPS study.
Hello, I'm Kristi Gamarel, she, her pronouns, and I am presenting with Sari Reisner, who is here, and I'll be presenting on ATN 167, Legal, Economic, and Affirming Peer Support for Trans Youth, or LEAP for short. So we felt like it was really important to start off with our team. It takes an enormous village for this protocol. We have an incredible wealth of expertise working on this protocol. For the sake of time, I will not go into everyone on our team, but you can see these incredible folks. And as Sybil and Lisa already introduced, many folks working across the ATN. This protocol is not possible without everybody. But the most important team members are really here. And here I will actually go through everybody. I'm just kidding. But we are a animal loving protocol team who cares very deeply about each of our pets. So in terms of LEAP, LEAP is really focused on addressing the pressing needs of transgender and gender diverse young people in the United States. We know that transgender and gender diverse youth experience are burdened by HIV with incredibly stark racial and ethnic disparities across both the HIV prevention and care continuum. In terms of HIV testing, engagement in PrEP services, linkage to HIV care, viral suppression. And we also know that intersectional oppression, so racism, cisgenderism, classism, each of these things collide and fuel social determinants of HIV. And some of the most pressing that we have seen in our work and our community partners have shared with us is the needs to really think about health-harming legal issues that young people experience, economic vulnerability, so incredible poverty that young people live in, as well as unmet gender affirmation needs. And when we think about gender affirmation needs, those are very holistic in thinking about the ways that young people are affirmed in who they are in their gender. And so that might be getting their names changed legally, or it might not be, but often it is very much about being socially affirmed. So being affirmed in who they are by society, as well as medical gender affirmation. So being able to access gender affirming hormones. And in this context, there have been several leaders, organizations that have developed programs to address these pressing needs, and in particular, Black trans-led organizations across the United States and globally, actually. And so there's really a need to build upon and lift up these community-led strategies and evaluate them and integrate them into a community-led prevention program to address both HIV prevention and care continuum outcomes. And so this work very much builds upon our community partners. So I'm pointing here to the Trans Sisters of Color Project. I work really closely with them in Detroit. And Liliana Reyes, who's wearing the beautiful headband, she's the executive director. And the Trans Sisters of Color Project really is focused on uplifting and impacting the lives of trans women of color through trans-centric programming. And since 2017, they have been offering those strings attached emergency assistance or mutual aid to their communities when they're in emergency, when they're in a financial crisis. Julissa Abad, who's also in this photograph, in 2020, she founded the Trans Name Change program here in Michigan that offers free peer and legal support to trans individuals. And so a lot of work has been happening here in the spaces in which I work in Detroit. And then Sari Reisner, who's here, has worked really closely with national organizations. So Carter Brown, who is the executive director of the National Black Trans Advocacy Coalition, which is a social justice organization led by Black trans people to address racism and inequities. And they also have done, through the COVID pandemic, have launched a national program to offer mutual aid and emergency assistance. Marissa Miller, who has been incredible on our protocol, is the executive director of Trans Solutions Research and Resource Centers, and which advocates for safety and universal access and offers social and health services, and also is doing a lot of programming around mentorship job programs for trans and non-binary folks across the country. And we've also been partnering with Bethany Hamilton. So if folks don't know, out of George Washington University, the National Center for Medical Legal Partnerships is an incredible resource. And essentially what they do is they provide technical assistance to healthcare organizations who are interested in embedding lawyers into healthcare services delivery, to address and ensure that we are responding to social needs. So that is a little bit of our background. So our protocol has 3 aims. The idea is to combine these community-led strategies to address social determinants of HIV. So the first aim is to test the effectiveness of our program on increasing HIV prevention and treatment outcomes, compared to a delayed control that Sari's going to describe a little bit more about the design in a few minutes. Our second aim is to see, so this is a status neutral program. And so we want to see, does this program intervention work across young people of different HIV statuses? Are there differences by gender? So this is inclusive of trans women, trans masculine folks, as well as non-binary folks, as well as by sites. And then assess, does this have an impact on addressing young people's gender affirmation, legal and economic needs? And then similar to LYPS, we're doing a process an implementation process evaluation, which also includes cost effectiveness, to see what is the impact and how can we scale this up, to think about sustainability. So with that, I'm going to turn it over to my collaborator and partner here, Sari Reisner.
Thanks, Kristi. So we'll talk a bit here about the design, tell you about the design of the study. So we have 7 LYPS sites in the US, and you can see these distribution here. A good coverage in terms of the Eastern and Southern, Western, Midwestern. We are in a particularly challenging climate in terms of trans youth and legislative environment. So it's quite a time to be doing this study. We're really excited. And the process evaluation that Kristi talked about, I think, will yield some really important insights as we're thinking about implementing research in different contexts. Next slide, please. So the design really is focused on, there we go. The design is really the following. So our eligibility criteria that we're looking at are being ages 15 to 24, so young people, identifying as with a gender identity that does not correspond with sex assigned at birth. So this can be individuals who are identified as trans, non-binary, or otherwise gender diverse, a really broad spectrum of folks. Identifying as a person of color, so Black, Brown, or other person of color. And again, this is really focused on addressing racial and ethnic disparities that we see in the HIV prevention and care continuum. Any condomless sex in the past 6 months, being English or Spanish speaking. We are going to implement the protocol both in English and Spanish, very important, and also willing and able to provide consent. The design itself is a waitlist control design. So, some of the challenges always in this is who are our comparison groups and what do we do with that? We want everybody to be able to eventually receive the LEAP package. So what we'll do is a waitlist control design. Youth will be randomized 1-to-1 to receive the intervention immediately, or in a delayed condition, they'll wait for 6 months to receive the intervention. We will follow participants quarterly for a 12-month period. And then we'll do enrollments in person at baseline, and then we can have remote options for follow-up. It's been our experience in implementing with trans and gender diverse communities that initial point of contact is such an important one in trust building. In a lot of the studies we've done, we've seen that makes a very big difference in terms of retention over time, and particularly if we're talking about a 12-month period. And particularly since we have a wait list, we want to make sure that we don't have differential follow-up for that group that's the wait list control. Okay, so what is the intervention? Then, we are addressing the 3 different components. These are community engaged strategies that are being used. The legal piece is focused around a health harming legal needs screener. So youth are assessing, kind of what's happening for them in the legal environment. So health harming legal needs could be something like needing a name change. It could be something like an outstanding parking ticket. It could be all sorts of things. This is sort of wrapped with an education session that's really focused on learning about legal empowerment and rights, and then having direct linkage to lawyers. So for those youth who are presenting with legal concerns, they get that linkage. The second component is addressing the microeconomic piece and the economic vulnerabilities for young people. This is focused around 3 educational group sessions. We provide immediate economic assistance of $200, and that also includes an unconditional microeconomic grant of $800. So the idea here is to get youth to begin thinking about how they could generate income using this $800, how they could apply it toward educational goals and objectives, and so forth. And they'll do that using sort of support from a peer. So there'll be a mentoring peer that they work with to do that. And then thirdly is the gender affirming peer support. So this is 6 individual sessions. They're one-on-one sessions between the participant and a peer. This is an adaptation of an evidence-based strategy, Healthy Divas, that's been used. It was developed by Dr. J. Sebelius at UCSF. It also combines peer health navigation. So it also kind of includes that component. We know that peer health navigation is an important component, has been shown to increase uptake of HIV prevention and care services. So it's these 3, addressing the legal and economic determinants, which, we could call kind of general social determinants, if you will, that maybe all populations face. And then also addressing this really gender affirmative peer support, which is really a trans-specific social determinant. Okay, so the program itself, the intervention itself, on the next slide is 10 weeks long, and it's every week, 1 session once a week. So, we kind of alternate between peer support, which you see in blue here, which is the one-on-one sessions. The orange are the the health harming legal needs pieces, so the screener and that economic empowerment session. And then we have the economic pieces around the groups, which are in purple there. We'll give you a little bit of a sneak peek here at some of the session and the content. So for the group sessions, in the next slide, please, we have a legal empowerment session that's focused on understanding how sort of legal empowerment relates to trans liberation. So really bringing a strengths-based lens here, looking and talking about what is a health harming legal need and the types of things that lawyers do. So going to a lawyer can be very intimidating and a scary process, particularly for folks who, maybe folks of color who've experienced racism and oppression in the system. So we want to make sure that we can get people that information and comfort. Working on financial planning, some strengths and passions focused work, like thinking through how they can spend that money that will be a way that will help them to do some future looking. So we know that future orientation is an important piece of young people. And then building credit and using it wisely. We all need that. And then the next slide, I'll finish this up quickly, is the individual sessions. So this is really focused on a holistic perspective, right, of gender affirmation and thinking about sort of taking care of one's whole self, which also includes sort of economic and legal pieces as being part of that holistic vision of health. So you can see here that it really focuses on gender affirmation, things like building peer support, recognizing successes and helping people to kind of problem solve, and so forth. And importantly, these skills are accompanied by kind of activities and applied scenarios. So we want youth to be able to kind of think through these, apply them, and then kind of have that in their own lives. So I'll finish up there and just say, we're really excited about this project. We love that it pulls from strategies that are happening in community, driven by the communities. It's holistic, so it's a multi-component package. It's focused on trans youth of color, for whom we see and events many disparities, unfortunately, in the HIV epidemic and related clinical outcomes. And we hope that it's really an equity-focused strategy that is addressing the social determinants of health, not just that are general for like legal and economic, but also that are trans specific. So thank you so much.
Thank you, Sari and Kristi. That was absolutely excellent. We're running a little bit slow here, so we're gonna hold. There's a good question for you all in the QA. We're gonna hold that till the QA and comment section after this panel. So hang tight, and thank you, Julie, for that great question. I'm now gonna invite Zoe, Kendrick, and Rodrigo to come forward. Put on your camera so I can highlight you. And we have a panel discussion with our CAB member and our subject matter resource consultants. So let's get you all started here. Rodrigo, Zoe, and Kendrick. And Kendrick, I know you have to run. You're a bit on a schedule, so we're going to start with you. And this is going to be the same question we'll ask for everybody. Let me just playing around with all of these spotlights I have going here. Sorry, hold on one second. Okay. So Kendrick, so tell us quickly who you are, why you're involved in the ATN, what you bring to the ATN, and what you hope to get out of your involvement. And then we'll have Zoe and Rodrigo respond to that same question. So go ahead.
So my name is Kendrick Forte. And one of the subject matter research consultants with state of Florida, Florida State University, as well as with the ATN. I've been working with the ATN and I've partnered with them since the last cycle of the ATN. So I've kind of been here maybe about, this may be going into my 7th or 8th year, at least being a part of research and being involved with the ATN. Why I'm here, my background itself is to bring forth just the aspects of letting people know I'm a voice for the youth in regards to right and wrong, or don't like this, try this a different way, offering up those different things so that way there's just different avenues and different opinions that can be brought forward to a conversation. Now, I'm gonna also bring a financial aspect as a budget analyst. So most people are very familiar with me when it comes to looking at numbers or trying to determine how the funding and what the funding can be used for. That tends to be where I mostly sit in at. And also what I like to bring out from the ATN is just being able to be a voice. And I also like to bring out those resources from the ATN and being able to pass those into the communities and the spaces that I actually frequent. So I'm also a member of Ballroom Community. I work at a university as well. So at least being able to allow those different things and to at least be able to go out and speak to the different youth within the different places where I actually reside in, and then being able to bring forth their input back to the ATN. So that's kind of where I sit.
Thanks, Kendrick. And I know you have to run. Do you have a second to answer another quick question?
I do.
Okay. Or are you able to, because I thought you said you had to leave at 10 today. So I'm just making sure we get
So
you.
I do. I was able to speak with a couple of my coworkers. I have to conduct the training. So I've spoken with a couple of my coworkers to make sure that they can sit in for me while I'm able to sit on the panel.
Oh, nice. Okay, good. So I can chill out and relax a little bit. Why don't we pop that question, the same question, over to Zoe? Go ahead, Zoe. So again, basically who you are, why you're involved, what you're bringing to the network, and what you hope to get out of the network.
Yeah, my name is Zoe Njamanze. I'm a subject matter research consultant. I'm based out of Texas. And Jim, would you mind putting those questions in the chat? I just want to make sure I stay on track and I don't get lost in my own thought.
Sure, I'd do that right now for you.
Thanks so much. I've been with the ATN. This is my 2nd year. I think that I do have a background in public health, with a particular focus in health disparities. I think something that I saw throughout like my academic life was the disconnect between research, literature, and the actual communities that were researching these communities, and the certain language that was used, like researching a community instead of partnering with the community. There are just slight things that I feel like can make the process feel like a more collaborative process. So this particular role really spoke to me because I felt like I was an integral part of research. And as a Black woman, with the studies focusing on my population, I feel like I can, speak to and be able to be that person at the table to call out things that may be increasing the disparity between research and the community. So I think that's a bit of a summary of why I'm involved, and what I bring to the ATN. I think like just being, taking into consideration like how the research calls to me, how I would see it as a participant, I think is really important. Like I said, I think that there can sometimes be a disconnect. So I feel like as subject matter research consultants, we're the first line of defense to kind of call out stuff and see stuff before it, has to hit market, so to speak. And I like just having that kind of safeguard to be able to catch things before they kind of get out. What I hope to get out of it, I think one of the joys that I have that I don't really think I've talked about to the other research consultants is it is just a joy to be able to connect with people across the US similar to me and be able to encourage them and motivate them throughout their journey. We do describe ourselves as young professionals, and we have had several research consultants go on and consult outside of the ATN, make that their business. And it's really nice to see that we are being valued within the research space, even outside of the ATN itself. So that's been a joy of mine. I also consult outside of the ATN. And so just hoping that, for those of us that do want that career path, that those options have become available to us, which I think just makes the field of science and research more equitable.
Thank you so much for that, Zoe. Excellent, excellent. Rodrigo, we're going to ask you the same question. Who are you? Why are you involved? And what are you bringing to the ATN? And what do you hope to get out of the ATN?
All right. Well, hello, everybody. Thank you so much for letting me be here and talk in front of the panel. My name is Rodrigo Cabrera. I am based out of Houston, Texas. I am the ATN member and the representative for...
Rodrigo, we're having some problems hearing you. Maybe your headphones, are you on headphones, or maybe you need to change your headphones? There's a lot of static in background. You want to try it again? We heard a second there. I think that sounds better. Go ahead.
Alrighty. I think it's better.
Much
hi,
better.
I'm
Thank you.
Rodrigo Cabrera. I am the no worries. I am the ATN site representative out of Baylor College of Medicine and Texas Children's here in the Houston Medical Center. I joined the ATN back when I was in my undergrad at U of H. The current project coordinator at Baylor reached out to me, or I was part of a couple different trials, and then she reached out to me, wanted me to get involved, and I did, and I absolutely loved it. I love the fact that I get to interface with not just my local community, but the international community, hear from so many different experts and professionals in the field, their ideas, and being able to get a sense of their ideas and bringing it back with me. Something that I am fortunate that kind of plays into what I can bring into the ATN currently is I work in biotech and I work in viral therapeutics. So being able to understand the process of how these medications are developed, and then also hearing all these protocols from going on around the country, I am able to mix it together and just form a broader idea of how to contribute to HIV research and approach to treatments. Something that I'm currently working on is just kind of taking that next step to be further involved in my community. Being in Houston, I think I have the privilege of working with quite a vast population and diverse population. It's a big city center. We have enormous suburbs around here that are very diverse. So being able to interface with them, get just a wide range of people in coming into the clinic or coming into Baylor and doing different research studies, I think it's just great. I am not sure if my audio is still going through right now because
We can hear
everything
you,
just froze.
Rodrigo. We can hear you.
Oh, sorry. Like the whole thing, just my signal's not great.
No worries, we
But
can hear
yes,
you.
I love the involvement. I love the opportunity, and I really wish to continue doing what I'm doing.
Awesome. Thank you for that.
That
So
is
the next question is I'm gonna start with Zoe, and I'm gonna ask so we have time to get through a few more. So the overall question is, what does meaningful involvement of adolescents and young adults in HIV research mean to you? I'm gonna pare that down a little bit to be, what is the key ingredient in your mind that is absolutely critical, crucial for meaningful involvement to be obtained? So I'm going to, and I see smile on Zoe's face. So you are definitely taking this on first. Then we'll go to Kendrick, and then we'll come back to Rodrigo. So the key ingredient for meaningful involvement to be actually obtained and attained.
Yes, I'm smiling because I'm the worst person for brevity. I think what it boils down to is equitable collaboration and feeling, if you feel like adolescents and young adults have something to offer, and trying to veer away from a more parental, custodial, or guardianship role, and understanding that for effective plans, you have to understand the people that you're preparing the plan for. And so that with that comes a very realistic understanding of behavior, of how people are living their lives. And it's not an opportunity to nitpick or discriminate or I guess vilify, but just taking it for what it is and kind of understanding what people bring to the table and how they walk in their lives and how they show up in their lived experiences. So I think it's just ultimately about that equitable collaboration and seeing adolescents and young adults as, it's not a place in research to create another hierarchical system where adolescents and young adults are under. That is just, it's just a copy and paste of what's experienced in the outside world. And so I feel like if we're wanting to engage adolescents and young adults, there should be a desire to restructure and differentiate from the system that already exists in everyday life, where we are kind of the last to be thought of or the last to be regarded or less valued.
Such great points. Thank you. Thank you so much for that answer. Kendrick, what say you about the key ingredient, the most important ingredient for you in terms of having meaningful involvement of adolescents and young people in HIV research?
For myself, meaningful involvement for adolescents and young adults is going to look like actually ensuring that you're able to listen to their opinion and making sure that you take them into consideration whenever anything is being done. What that does mean is being able to have those young people and young adults engaged in the research activities in the beginning of the research stage, and then allowing them to go through the transition of their research and what that does look like. An additional involvement is going to be allowing those adolescents and young adults the opportunities to not just be involved in the research, but to grow with the research as a whole. So that does mean being able to sit in a lower position that they may start in, and then being able to move up in their role so that way they're not just a part of the research, but they start to get the opportunities to even make the research themselves and offer those suggestions that they need to the people, the doctors, and different researchers, so that way they feel as if their voice is being heard, but they're also sitting at the same table with the people that they might not necessarily know, but just being able to engage in that conversation and let them know that they are important in the research because the research is for them.
Thank you, Kendrick. And Rodrigo, we're going to kick it over to you. Same question.
Alrighty, I do think that one of the key ingredients is, we are serving a population, we are serving our communities, and to a degree, I feel like we can sometimes get lost in technicalities to research the technical, stuff surrounding it, but actually seeing the benefit, seeing that change in the people we are serving, to me, is what is key. I do think that, by involving them into this research, by getting them involved, quite frankly, you're forming a sense of community around somebody who may not necessarily have that or feel connected to other people who may be in the same situation as they are. They may feel isolated before and then, found people they can relate to. And to me, that may form, inspiration inside of them, or seeding curiosity to not only just participate, but learn more, form a type of drive. For example, when I first started doing the ATN, I had a general biology career path. I was, just doing medical clinical research and everything. But being here really truly drove me into going more into viral development, therapeutics, seeing how I could further aid in this research, and seeing the participants that come into Baylor, just kind of following through with them and seeing that they kind of too follow a similar pathway of being involved leads to them wanting to be more involved in their community. How can they participate further? To me, that's the key, to just get people motivated and immersed into what we are doing.
Thank you for that. So now I'm going to open this up to whoever wants to answer. And we'll have this, maybe one more, and then we'll move on to final QA and commentary and answer some of the questions that have come in through the QA. But I'm answering, and this is building on what you all have already spoken about. But for those of us who aren't in the youth category, and I know I think of myself as youth, and then I look in the mirror and realize I am not in that category anymore. And we may find it challenging, it may be difficult for us to relate or speak to you. So what are your recommendations for talking to and communicating with youth that's respectful and engaging, and really speaks to what you were saying, Zoe, that's equitable and is not about hierarchy? So who wants to jump in and take that on?
I will jump in.
All right, thank you.
I will jump in because I facilitate a youth council, but they're high schoolers, so they're youth. And I think that what this question speaks to is that there may not have been the cultivation of a safe space for youth, because I really think that if you have youth in your vicinity, if you have them around you, that you will learn the lingo, and they will definitely call you out if you say something that is behind the times or just doesn't resonate with them. So I would say that if you're finding that you're needing to open those lines of communication, or you're having difficulty communicating, I think that you kind of have to break that barrier literally by creating a safe space. I think a lot of times when you're working with youth, that not saying that the lines of professionalism should be blurred, but you have to make it a safe space, or else no one is going to communicate with you authentically. These are people who you're wanting them to speak about their lived experiences. You're wanting people to tell you very openly what their thoughts are and what their feelings are. And so doing that means creating a relationship. And a mostly professional relationship is incredibly sterile. It's very difficult for me to want to open up or to tell you my true thoughts in a way that is a little more like casual. And so if you're really wanting to grow in this area, I think it's about cultivating a safe space, but also making one that feels warm, that feels comforting, that is inviting. And I think you'll start to learn the lingo. You'll start to learn, you know, how people around you talk and what's hip and what's hot and everything that you're wondering. I feel like your youth will like actively and willingly share that information because they feel like it's a space where they can do that.
That's excellent. Thank you, Zoe. Kendrick or Rodrigo, do you have anything you want to add to that? Any recommendations for how people who are not youth can better communicate?
Yes. So, you know, even being only 24 years old, sometimes I can feel disconnected from the population that we are immersed with. Sometimes, you know, the culture around it, I don't get it or I'm out of date, which is kind of shocking to some degree. I try to relate with them, but something that I found that can be very beneficial is simply whenever you get them to interact with each other, whether that is, you know, a buddy system or pairing them up or social gatherings, meetings, something, and you kind of see how they interact as they are more comfortable with each other than a researcher or somebody else, you can kind of just study and understand how they are communicating and then implement that in your strategy going forward. I saw there was a study that I kind of just they had this really I thought was really effective way of engaging with their study population was that they formed a type of text log, an automated text log that they would have. It was a fake person per se, as if they were that was reaching out to them, but it was smart. The system was like they would text them, and then based on the answer, it would divert to a different question, divert to a different statement, and based on that, you gain knowledge of how, like, what do they like, how do they like to approach conversations, how to not approach conversations, and just being able to collect that data, you're able to just further understand how to engage with them.
Thanks, Rodrigo. And Kendrick, do you have anything to add? And I would just ask that it's a brief add at this point, since we have a few questions before we get to the end of this webinar. Anything you want to add, Kendrick, though, around recommendations?
I have nothing to add in regards to that piece.
Okay, fair enough. Thank you so much. I'm going to, I'm kind of dealing with all of these crazy spotlights, but we are now open for questions. If folks want to raise their hand or put in questions in the chat. I know Julie Patterson, if you are still here, you asked a great question in the QA. Would you like to come off mute and ask that question, or I can ask it for you? Putting you on the spot. There you are. You see.
Hey, Jim, can you hear me okay?
Yeah, definitely. Go ahead, ask your
Morning.
question, Julie.
Yeah, thanks. I was just expressing enthusiasm about the LEAP trial because of its inclusion of people who identify as non-binary and kind of, you know, the not having to identify as trans. And we haven't really seen this in the other research networks unless, I mean, I might have missed some things, but I'm just curious if you're imagining a pathway where this will influence the research agenda in adults as well? And if so, like, have you been in conversation with people and kind of what that looks like? So love to hear about it. Thank you.
Thanks for that great question. So Sari and Kristi, and the rest of the network too, you can jump in if you like. This is a great question.
Well, thanks so much for that question. It's a great one. Yeah, I think there is an increasing, importance, obviously, of recognizing non-binary individuals. And I think that, some of the ways that we categorize prevention, I think non-binary folks are in there. It's just not captured in terms of the questions that we ask to be able to identify them. So I think one great question is, like, in the field in general, thinking about, transgender women. And categorically, that's the group that we sort of ask the question of. But within that group, it's a very heterogeneous population, right? And people who are sort of trans feminine on that spectrum, many of whom may identify as non-binary. So I think it's, being more explicit about how we ask the questions, and also sort of raising the fact that, as gender identities, are continuing to evolve and, societally and otherwise, that we're opening that agenda. There's certainly more studies coming out. I'm doing some work in transmasculine communities, and non-binary transmasculine people are a big part of that. So yeah, I would love to see that agenda. And I think the ATN and really kudos to Lisa and Sybil for bringing this and lifting this up in this way to bring visibility to this population. So hopefully it's the beginning. Julie, thank you for bringing that up. Hopefully it's the beginning of moving that agenda forward. So thank you so much.
Yeah, and I would just I think there is a movement in different research projects and research teams. One of the things that the ATN did was we actually had a think tank that informed sort of best practices on how to ask gender and be inclusive. And so I think that is something that, we would love to share out that process. It's an evolving process. It's going to always be fluid and changing, and we will come back to it as things change. But I think that is something that, I know several groups do siloed, but I think it would be really important for all the networks to do as well. So yeah, and we're happy to share our resources too on how we got to our gender and questions as well.
Thank you both. Anyone else from the network want to add anything to that? I have a follow-up question, but I'll pause for 1 second. Okay, here's my follow-up question, and it ties into this. So I was talking to a trial recruiter last year at some point, and a lot of trials now, rightfully so, have very clear quotas for getting diverse representation into the study, and there's quotas for trans men and for trans women, and they were saying, we're running into issues recruiting trans folks. A few years ago, some of the folks who may have identified as trans are identifying as non-binary or gender fluid, and it's kind of like upsetting the apple cart a little bit. And on one hand, this is an amazing thing, right? People can identify themselves in all of these really diverse ways, and they don't have to be, a label doesn't have to be put on them, and people are feeling more empowered to do that. But the folks who are like, counting the bean counters and all the ways we count beans, it's making it really complicated. So how do we ensure like that diversity is happening? And when we have now this really amazingly expanded list of ways that is only going to get bigger, of ways that we are identifying ourselves. So what do you all think about that?
I mean, I can just say that we like to upset the apple cart. Sorry, Sonia, I know you're on, and I see some folks, but we're okay to upset it. The other thing that I think, to Kristi's point, around kind of creating this think tank around measurement, was that the first part is how you ask the questions. The second part is how you analyze the answers, right? Because, you're right. If you have, 200 people in the study and you have 200 different ways that people, self-identify, it can be challenging. And I don't have the answer to exactly how you do that. But I have, I think that we've enlisted the greatest minds to actually think about that, including, representation from populations that we're going to be reporting on. So I think, there's more to come in that, but I would just say that, we don't like to think about, quotas in that way. We just want to reach the population that can benefit from these amazing interventions that these PIs are putting forward. So, so more to come. And again, if folks have thoughts on that, again, we are I would say we are an open network, in that we really want to benefit from all the work that's being done outside the network, the thoughts, the ideas, the expertise, the lived experience, you know, all of that. So please, Sybil and I really do mean it. Reach out to us anytime, and we're happy to talk and you know, bring you into the ATN family, as we like to think of it.
Thank you, Lisa. Would any of Lisa's colleagues like to add to that or expand on any of that? Okay.
I would just like add that I
Please.
think a lot of us in leadership positions in the networks are old, getting old. And I do think like this is an example of where sometimes the way the HIV prevention field and care field thinks is still stuck like 30 years ago, even if we're bringing new innovations in. And it's just a call, I think, like Lisa said, that we just need to be open to like doing things really radically different sometimes. And particularly like, oh, well, this is the way we've always done it, so we have to do it this way because that's how we do it. I've heard that increasingly. And I just want to, yeah, this is one example of where I just think we need to be more open. Even if we're doing clinical trials, we can still be innovative and creative. So a call to younger people to call the old people out and like don't back down. It's really important so that we move the field forward and don't get stuck.
Excellent points, Audrey. Thank you for making them. We are down to our last minute. So is there a quick question or comment? You know, keep it open for another moment or so. Any final words of wisdom from anyone of our speakers, something you didn't get to say, but here's your chance before we sign off for today?
I just want to thank you, Jim. I don't think you did. Jim is part of the ATN, so Jim sits on one of our leadership groups. He is a voice for change and to keep us, even though you say you're not young, you do keep us thinking about that. I just make one comment is that when Kristi and Sari were creating their intervention, they had much smaller micro grants, and Jim was like, you know, this is weak sauce, and and he basically pushed them to really and pushed us, Sybil and I, to increase the budget for the study to actually, you know, bring forth grants that were that, you know, I think were stronger sauce, maybe not hot sauce, but at least stronger sauce. So I just want to say thank you for organizing this webinar and inviting us, and for your contribution to the field and your advocacy. It's really an honor to have you involved and to be able to present with you. So thank you.
And kudos to DJ Kimberly, because you know you rock a webinar, Jim Pickett.
Yeah, DJ Jimberly is the bomb. And I have to say, today's list was all outsourced from the brilliance of the ATN. And I'll just say, one of the things that attracted me to the ATN, and when I was, you know, when you all lured me into your beautiful web of love, I love the upturning of apple carts. I love pushing change and not, you know, settling for the status quo. And that's definitely something that really attracted me to the network. And I think the studies that were presented today are really examples, great examples of not standing for the status quo and throwing over the apple cart and figuring things out and doing things in new ways. We can't keep doing the same thing over and over and over for going on 4 decades. So thank you to the ATN. I want to thank all of our really amazing presenters, all the PIs on the different studies. Thank you for being here. Thank you to our subject matter research consultants and our NCAB members, so Rodrigo, Kendrick, and Zoe. You are such a critical part of the ATN. And thanks for all of your efforts today and every day that you are working on all these issues. And finally, really thank you to everyone who joined us from the United States and all over the world. We know this was very US focused. This is a US centered network, but there are things we can learn from each other globally for sure. Sorry if you didn't get all the information you wanted from your own local context, but hopefully we gave you some resources to check out. In the next day or so, you'll get a follow-up email with a link to the recording, the slides, and all of those links that we shared in the chat. I hope to see you all on February 29th. It only comes around every 4 years. We're having a webinar on that day on Africa and pandemic preparedness. It's going to be a hot one. So hopefully you will join us for that. And with that, I'm going to officially close out the call. Have a wonderful day, afternoon, evening, and tomorrow. Take care.
Thank you.